Hello and welcome to today's OneOp webinar. I am Kaylin Goebel Mathis and I am a program development specialist for OneOp. I will be moderating today's session on drug trends in military adults, essential insights for mental health professionals. Before we begin, I'd like to give you a brief tour of our webinar platform so you can find your way around if this is your first time joining us. Hopefully, you are currently able to view the slides we're sharing on the screen. If you can't see them or are having any other difficulties with your technology, please email us at contact@oneop.org for tech support. We hope you will join us and engage in the chat pod today. I see we have a few folks already welcoming in. Um, and as service providers working with our military families, we welcome you to talk about your experiences as we go through this presentation. So to embed the chat pod so you don't miss any links or conversations and can contribute and we can all view it, please simply place your cursor over the shared slides. You should then see a toolbar pop up across the bottom of your screen, and from there, just click that chat bubble icon. When typing questions and comments, please make sure you have everyone selected from the drop-down response options so that everyone attending today can view your comments and engagement in the chat. Slides and resources are available for download on the webinar event page, and I will be covering continuing education information and how to get those certificates at the end of the webinar. So please stay tuned until the very end if you're hoping to obtain CE credits or wish to receive any kind of certificate for today. Closed captioning is also available for the webinar, and you can turn on subtitles via the Zoom toolbar. Thank you so much for joining us as we continue our partnership with the Department of Defense and the U.S. Department of Agriculture to expand the readiness, knowledge, and networks of professionals like yourselves supporting our military service members and their families. This session will be covering the topic of drug use and drug trends, and we acknowledge that these topics may be distressing, these conversations. So if you need to step away at any point or pause for your own comfort and your own wellness, a recording of this presentation will indeed be available for later viewing on the event page. That on-demand recording will be available typically within 24 to 48 hours. You can check back on that event page as the one-stop shop so you can get your slides, your CE information, any additional resources. John will be covering some really great resources today, and all of that is on the event page, as well as the on-demand recording of today's session will be available again within 24 to 48 hours. So if you need to step away, please feel free to do so, and you can circle back to the recording at a later date. For today's session, we are joined by John Haynes. John holds a Master's of Science in Social Work and is internationally certified prevention specialist with 32 years of experience in the field of substance use disorders, juvenile delinquency, trauma, and child welfare. He is recognized as an expert in addiction and adolescent brain development, and he currently serves as the Chief Operations Officer of Challenge of Tarrant County, a nonprofit agency whose mission is to confront substance abuse by identifying the needs, educating the community, mobilizing resources, promoting collaboration, and advocating for sound public policy. Before I hand things over to John, a few quick reminders. Again, that recording will be available on the event page. You can just check back there for that video. A PDF, a downloadable PDF of the presentation is also available there, as well as a list of resources that John will be covering today. And again, CE information, I will cover that comprehensively at the end of the session, so stay tuned if you need that information. And our presenter will also be answering some questions at the end of today's presentation. We hope to have a little bit of time for John to field any questions you may have. So please feel free to pop those in the chat pod. And again, please make sure that everyone is selected from the drop-down menu, that you're sending that to everyone so we can all view your contributions in the chat pod today. And with that, I am happy to turn things over to John to begin today's presentation.
Thank you so much. I appreciate it. Welcome, everyone. I'm glad to have you with us this morning. Our learning objectives for today. We've got three basic learning objectives: to identify drugs that are considered emerging health threats and the impact that these drugs are having on military communities, to demonstrate knowledge regarding drug paraphernalia, methods of use, and new technology being used in the drug culture, and discover at least one over-the-counter or OTC product that is commonly abused for recreational purposes. We have a lot of material to cover today in a very short time frame to do it in. But my hope is that we'll be able to get through all of these slides and leave at least 10 or 15 minutes at the end for questions. So please do enter any questions you might have onto the webinar chat so we can answer those for you. All right. And our first little short answer response today: what are you hoping to get out of this webinar? What are you hoping to learn today? Is there a particular drug trend? Is there something you've heard about? Is there an issue that is particular in your community? We would love to get your response in the chat pod so we can try and tailor make some of our responses to address those. So if everyone can take a moment and flip over to the webinar chat pod and put in what you would like to learn today, that would be awesome. Right. And with that, I'm going to let our moderators monitor that, and we're going to move to our next slide. So, nationwide, drug overdoses have claimed the lives of 107,543 people in the United States in 2023. 81,000 of those deaths, over 81,000 of those deaths, involved synthetic opioids, primarily fentanyl, which, of course, is one of the major epidemic issues we're facing in the drug trend currently across the United States. I will tell you, drug overdoses have increased exponentially. In 2002, we had about 8.2 deaths per 100,000 people. To up in 2022, it was 32.6 deaths per 100,000 people. And the people who are dying of drug overdoses have changed dramatically. It used to be, it was primarily people who had a long or extensive history in using drugs, usually the harder core drugs like heroin. Now it has spread out across the lifespan. We have young children who are overdosing. We have teenagers who are overdosing with their very first use of a pill. We have young adults. We have older adults. It really has become a systemic issue for all of us to be addressing. Not that anyone should ever die of a drug overdose, but it really has impacted us on a much more global level than ever before. So as we sit on this webinar today, we know that there are 294 deaths each day, or about 12 an hour. So for the hour and a half we have together, about 18 people will lose their lives due to a drug overdose. The majority of those because of fentanyl or an opioid. It's a staggering loss when we stop and think about the loss of human potential, the loss of life, the impact on families. It truly is almost overwhelming. And this epidemic has been in process since the late 90s to the early 2000s and has just continued to increase. Now, I will tell you, with the last CDC stats released just a week ago, there is about a 10% reduction in deaths from April of 2023 to April of 2024, which is awesome. We're glad to see those numbers coming down. However, that is as a whole for the entire country. There are still areas within the states where we're seeing increases in drug overdose deaths. I'm speaking to you today from Fort Worth, Texas, and I'll tell you the state of Texas has seen increases the last few years in overdoses. Now, granted, we were a little late to the epidemic, at least in tracking the epidemic, but we continue to see increases each year currently. So while numbers in your area may be dropping slightly, we're still seeing overall increases in other areas. So, drug trends in military populations. Now, I want to give just a few caveats about the stats that we're going to be reviewing, right? First, we know that most of the published stats for military populations tend to focus on soldiers, on people who have been deployed, on veterans. So we don't have as much information as I would like on overall military health. We're hoping to see some of that get published and have some additional access to that data. But the drug trends that we do have, I want to point out just a couple of things to remember as we go through them. First, you'll hear me talk a lot about the adolescent brain today. When I mention the adolescent brain, we're talking ages 12 to 24 because our brains don't fully mature until we're around 24 to 25. So when we're referring to adolescent brain development, I'm really referring to that age group of 12 to 24, even that 18 to 24 time range where we know is usually where people join the military. That's usually the age bracket that we see joining. So know that a lot of those stats do correlate across the board. So, and if there's any specific data that I need to explain, I'll be happy to do that, or we can hopefully generalize to some degree with this specific data. All right, so what can providers do? We know for a fact that in the 2021 Health of Force report, substance use disorder diagnoses among soldiers were the highest among those less than 25 years of age. That comes to us from the National Institute of Drug Abuse back in 2019. This seems to be continuing, it seems to be remaining true. We know under 25, our brains are still developing. They're still not fully myelinated and fully protected against the impact of alcohol, tobacco, and other drugs. So it becomes critical as a provider to engage with those young adult service members to start building healthy, adaptive coping strategies and increasing protective factors that we can to prevent the diagnosis of a substance use disorder. Speaking as a prevention specialist, it is always easier to prevent an issue than to treat an issue. So always keep that in mind as we're going through these stats. Our primary focus is how can we intervene at the earliest possibility. And the first stop is prevention. And that work is critical to helping people maintain long, successful, healthy careers and lives and family structures. So service members may be more likely to abuse alcohol than civilians, particularly in levels of binge drinking. Again, a NIDA stat. Active duty service members may see drinking as part of their culture, which we have seen. Drinking alcohol may serve as a means to connect or de-stress with fellow service members, a social lubrication, so to speak. We see this a lot in our college campuses, and it may end up being modeled as a way of handling stress within a military unit. It certainly is in lots of different sectors of our communities. And then, of course, there are some unique challenges for combat deployment. Permanent changes of station, prolonged work hours, unique sets of military-specific stressors that may contribute to substance misuse as compared to the stressors that are experienced in the civilian population. So having these three things, these three trends in tandem means that there is a risk of developing a substance use disorder. And our jobs are to identify those risks and those trends and try and engage with people to prevent that ongoing movement through substance use disorders. We also know that reported rates of illicit drug use increase when active duty personnel leave the military. We know for a fact marijuana accounts for the vast majority of illicit drug use among veterans, with about 3.5% reporting use and 1.7% reporting use of illicit drugs other than marijuana over a 30-day period. We see this a lot. Challenge of Tarrant County, the agency I work for, we actually have partnerships with our two largest veteran-serving universities, Weatherford College and UT Arlington, which actually hosts one of the largest veteran populations in the nation. And substance use has been an ongoing issue for those veterans going back to school and having to adapt and adjust to that current environment. There are several factors that play into that. We're going to talk about some of those now. Service members have an increased risk of developing a substance use disorder, especially for those who have been deployed to combat situations. And despite higher rates of substance abuse, deployed military personnel often have very low rates of referral to substance use disorder treatment services, which can often be attributed to high levels of stigma. Stigma and shame around substance use is still very pronounced across all sectors in the community. Oftentimes, substance use is still seen as a more morality issue rather than as a treatable brain disease. What we know from a treatment end is that substance use disorders can be treated with the same efficacy as hypertension, diabetes, asthma. There are very evidence-based, very directed treatment services that can help people obtain long-term recovery and maintain that recovery. We know that PTSD occurs more significantly among military veterans than civilian populations. About 18% of post-deployed Army soldiers experience PTSD, as opposed to about 6.8% of the general population. Trauma plays a huge role in substance use disorders. We see a strong correlation between PTSD and SUD disorders, not just in the military population, but also in the general population. If we're looking at adverse childhood experiences, which is trauma experienced as a person under the age of 18, those who have higher ACE scores or adverse childhood experience scores also develop substance use disorders at a much higher rate. Now, the impact on military populations. Outside of combat deployment or other traumatic events, there are a number of other cultural factors that can exacerbate alcohol and drug use. It can include the easy availability of alcohol at military bases, which is a concern. College students may not have the income to buy alcohol, but service members, even being underage, do have the income that can be used to purchase alcohol. And there's a workplace culture among military personnel that can be concerning, particularly the stigma related to problematic substance use and the fear of those negative consequences in asking for assistance. And then prescriptions for pain medication among military service members, generally related to combat-related injuries or strain from extreme physical exertion, have increased dramatically over the last 20 years. As a result, prescription drug misuse and opioid use disorders have become a concern for military leadership. This, once again, is not only within the military. We, of course, have seen over the last 20 years wave after wave of an opioid epidemic. And we're going to talk a little bit about that now and how this came about and why it's come about and what we can do to address this. So let's start off by talking about opioid receptors. We have a wide series of opioid receptors, both in our brain and our spinal cords. They serve important purposes because our brain actually creates opioids. They enable us to achieve a goal, short-term goals, typically. They decrease pain. They increase motivation, increase confidence, increase that sense of reward, which is that dopamine molecule, that neurotransmitter that really is all about reward. It reduces depression and anxiety. It increases pleasure in current activities. And it can increase warmth liking of warm things, a sense of love and connectedness, and interpersonal bonding. So opioids play a huge role in our daily life. Now, where we have started falling into issues is when the pharmaceutical companies started marketing OxyContin specifically. For the longest time, pain was something that people tolerated or lived with. And then in the late 90s, pain became a fifth vital sign, something that all doctors and all nurses and all medical personnel were asking patients to rate their pain from 0 to 10. We fell into this trap of the pharmaceutical giants who promoted a product knowing its addictive potential, yet wanting to continue to push this product out. And unfortunately, in most medical schools, there's less than 8 hours of training on synthetic opioids, which created a variety of issues. So doctors continued to prescribe medicine designed to alleviate pain that unfortunately got a whole generation addicted to that medicine. There was not enough research behind it. And what research there was, unfortunately, had been not presented accurately or factually. So let's talk about efficacy of pain medications. This is looking at acute pain. So not chronic pain, but acute pain, something that you've injured, that you're feeling that pain. It's a newer pain, something you're struggling with today. So Cochrane's review did a wonderful study looking at and asking people what worked best to relieve their pain. So looking at a 50% pain relief, they looked at ibuprofen, acetaminophen, ibuprofen 400 milligrams, oxycodone 15 milligrams, Oxy-10 and acetaminophen 1,000, then ibuprofen and acetaminophen together. And this is what we found out. So only 37% of patients experience 50% of pain relief with ibuprofen. With acetaminophen, it dropped to about 28%. With ibuprofen 400, it went up about 3 percentage points to 40%. For oxycodone, only 21% of people who were taking an oxycodone tablet experienced 50% pain relief. When you mixed oxy with acetaminophen, that only went up to 37%, which is the same as an ibuprofen tablet at 200 milligrams. But when you look at ibuprofen 200 and acetaminophen 500, it jumps to 62% of patients experience 50% pain relief with the mixing of a Tylenol and an Advil. And in fact, that has become one of the new gold standards of treating pain, is alternating between ibuprofen and acetaminophen. Now, when we move on to our next slide here, you're going to see, again, in the blue bars, this is what people experience as pain relief. And then the green lines are what prescribers, so what doctors thought was most efficient and most effective. And if you look, so the number one pain reliever, the 62%, only 1% of doctors thought that was a treatment outcome that they should recommend. Whereas morphine had a 55% prescriber thought process as effective. Oxycodone had about 20%, and then the rest were at varying levels underneath 5%. So you can see there's a lot of discrepancy between what actually worked for people and how doctors were trained, usually by the pharmaceutical companies, on what was most effective in treating pain. This was truly the beginning of our opioid epidemic. So the next slide gives you some information that you can find on our challenge website. We've been working in this field since actually 1984, but we've been addressing the opioid epidemic since early 2000s. We know that the first wave of the opioid epidemic was prescription medications, those natural, semi-synthetic, and methadone that were either illegally obtained or prescribed, and people were doctor shopping and having several prescriptions. That's kind of what started off the first wave of this opioid epidemic. Then in 2010, black tar heroin and heroin overtook the opioid crisis because as people began to tighten up access to the prescription pills, heroin started presenting itself as an alternative. And in 2013, we started to see synthetic opioids being manufactured, including fentanyl. Fentanyl is an amazing drug when given to somebody in a surgical setting and in a hospital setting. Very quick acting, very quick to burn off, but illicitly manufactured fentanyl is a very different animal. And now, since 2013, we have continued to see fentanyl make its way into drug supplies across the board. So it used to be the only time you found fentanyl were in illicitly manufactured Percocet pills, the blue M30s. Now we're seeing fentanyl-laced cocaine and meth in pretty much all our populations. One of the things Challenge does is we operate the Family Recovery Court. So when we have a case in Tarrant County where a child is removed because of a drug or alcohol issue, they're sent to us to be assessed and entered into one of our programs. We will have participants in our programs who, on their first drug test, dispute those results with us because they're positive for an opioid, primarily fentanyl. And they'll say, well, I don't use fentanyl. I only use cocaine or I only use meth. The reality is, since all that manufacturing has gone back to the cartels continue to use fentanyl, illicitly manufactured fentanyl, to increase the addictive potential of the drugs they're sending across the border. This, of course, has resulted in the staggering opioid and overdose epidemic. In fact, the cost to the U.S. economy was $1.47 trillion in 2020, and that's not factoring in the human, the loss of life, the loss of everything to these families. And we're going to hear from one of those families in just a minute. Fentanyl itself, 2 milligrams of fentanyl is considered a lethal dose. It is the amount that you could fit on the tip of a pencil. So a very small amount of this drug can be lethal. We liken it to, especially when we're training adolescents and young adults, the way the cartels are manufacturing fentanyl is not a structured and regulated process. They're mixing fentanyl in without any quality control, obviously, and without knowing exactly how much fentanyl ends up in each pill. Sort of like making chocolate chip cookies. You know, if you're making chocolate chip cookies and you throw your chips in and you stir it up, you know, you're going to have some cookies that have more chocolate chips and some cookies that have far fewer chocolate chips. And you don't know until you pick up that cookie which one has lids. The same principle applies here for these pill presses that have been utilized to flood our markets with illicitly manufactured fentanyl. The first pill may be fine. The second pill may have a lethal dose. We see it happen often. And for every one lethal dose that we have, one overdose that ends in a death, we have about 13 non-lethal overdoses where either a bystander was able to intervene and get medical assistance or the person was able to recover from that drug overdose. And it continues. So now that fentanyl has, as we begin to educate communities about fentanyl use, we've seen xylazine introduced to these pills as well. Xylazine is a large animal tranquilizer. It's used during surgical procedures as an anesthetic and as a tranquilizer. We now have vet shops that are being broken into on a regular basis for their xylazine supply. Xylazine is a very tricky drug to handle, and there's no reversal agents available to us outside of an emergency room setting. Fentanyl itself, and people ask me frequently, why would the cartels start adding in xylazine to the fentanyl? Like, well, fentanyl itself is a very quick burning drug. It burns off very quickly and leaving users needing to go out and re-up. Xylazine, by adding xylazine into that mix, you're giving that fentanyl what we call in our circles legs. It means that that fentanyl high is going to be increased from about 4 to 6 hours to about 12 hours with the xylazine. Unfortunately, xylazine is a much trickier drug. Both of them are respiratory depressants. Both of them cause your heart rate to slow down, cause respiration to decrease, which always triggers that risk of a fatal overdose. Last year in 2023, 30% of all the fentanyl powder seized by the Drug Enforcement Administration contained xylazine. That was up about 25% from 2022. So we're seeing this happening more and more with each passing year. Unfortunately, our reversal agents, such as naloxone, do not help in reversing these overdoses, which is incredibly challenging. We've also seen the introduction of nitazines to the drug supply. These are powerful opioid analgesics that were first developed back in the 50s and 60s. Right now, we're only seeing about 1% or less than 1% of the opioids that the Drug Enforcement Administration is picking up have nitazines in it. But that is projected to increase because in our hotspot areas, we're beginning to see more and more of those drugs. Naloxone, which is a reversal agent for opioid overdoses, will work on nitazene, fortunately, but usually you end up having to use multiple doses of naloxone to reverse that overdose. So historically, young adults have gotten prescription medications from friends, from family. There's always somebody who held on to those last few Vicodin tablets from the root canal or, saved grandmother's Vicodin for whatever reason. Drug transactions have changed dramatically in the last several years, especially following the COVID pandemic. What happened is a lot of drug transactions moved to texting, to social media, to the internet. So oftentimes, in fact, in our area, a good 80% of drug transactions are occurring first on social media through apps such as Snapchat and WhatsApp, and which we'll talk about in a few minutes. And dealers are able to communicate what they're currently holding by using a series of emoji codes. So if you aren't aware of those emoji codes, you may be missing something in regards to monitoring your child's use of social media, being aware of what you're being exposed to through those algorithms on Snapchat and WhatsApp and X and all the others. It really is amazing. There have been a couple of new studies that have come out recently talking about how quickly a 13-year-old on Snapchat is introduced to a drug ad of some kind or an overture for a drug sale. It can happen within 13 hours of first being on that app, which is amazing. Those algorithms, based on their peer group, based on projections of people their age, immediately start feeding some of this stuff into what they're seeing. Here are just a few of the social media apps that we have seen utilized for drug transactions. The DEA has to keep a very close watch on it. Our local law enforcement agencies will tell you that, especially on apps like WhatsApp and Snapchat, where messages are designed to disappear after being read, it makes following up on that and tracking that outbreak from that one particular transaction makes it incredibly challenging. And a lot of parents are blissfully unaware of their child's presence on social media. One of the things that challenge does is, I'm going to date myself here, back in my childhood in the late 70s and early 80s, at 10 o'clock each night, there was a little PSA that came on. Any of you all remember it? Feel free to throw yourself in the chat if you do. It's 10 p.m. There was a sound clip, and then, do you know where your children are? It was just a reminder to parents, have your kids made it home? Be aware of what's going on in their lives. We're now having to do that, but talking about kids' social media lives, because these social media apps change so quickly that keeping up to date on them, being aware of them is a challenge for most parents. And most parents feel completely unaware or flabbergasted on how to really safely monitor their child's use of social media apps. So this is a project that we did back in 2022, each year during Red Ribbon Week, which happens the last month or the last week of October. We do parental engagement pieces and community engagement pieces, trying to educate the community about what's happening in our community regarding drug trends. In 2022, we brought together 5 Tarrant County parents who had lost either their adolescents or their young adults to a fentanyl overdose. We brought them together. We created some video clips of them talking to other parents to educate, because what we do know from a prevention standpoint is that even if you don't think your adolescent or your young adult is listening to you, they really are. In fact, parents tend to be one of those primary prevention factors that kids look to when struggling with substance issues. So this one, I'm going to go back to the previous slide, and we'll start this up. This woman, her name is Danessa. She's going to tell you her story of her child and what happened with his death.
My name is Donitha Campbell. My son was Kendall Dwayne Campbell. He was 16 years old when he passed on January the 9th, 2021. I would say my favorite memory that just sticks with me is more of a recent memory. Is him and my daughter was in the kitchen, and anyone that knows Kendall know he can eat. So we were all in there just hanging out, and I acted like I was going into the bathroom, and him and Keely was in the kitchen just laughing. I had my phone out, and I was like, I wanted to let people see how he be eating his food. He's like, Mama, what you doing? I was like, nothing, Kendall. He's like, but Mama, you making it obvious. I was like, what are you talking about, Kendall? He's like, Mama, I see you recording me. It was always fun and laughter with him, and those are the memories that I keep and play over in my head the most, is the ones where we were just being us, having fun. Kendall was an athlete. He had honestly, both his dad and myself were athletes, so it came to him naturally. He started off playing pee-wee football, and he was naturally good at that. And then we introduced him to basketball. He was one of the smallest kids on the team, but he was the mightiest. We were doing everything we could to get him ready for his next step, which was his goal was to go to North Carolina and be a Tar Heel. That was his ultimate goal, was to play for the Tar Heels. And unfortunately, we didn't get him there, but I knew if we were going in the same path, we would have been able to get him there. It was so unexpected. I know most deaths are, can be unexpected, but this one was like a shock to everyone. Kendall was a ray of fun, a ray of sunshine. He would be the last person you would think would take a pill, and a pill that was not prescribed to him. And then on top of that, a pill that was laced with something. So it was just like, I need to let more parents know, it could be the one time that all the bad things align, and then it's your kid. So I don't want people to think, oh, my kid won't do this. Well, I thought that too, and look where I'm at now. So we're thinking at some point, at some time, he decided to take a pill. Well, get a pill, but he didn't take it until that day. So what we're thinking is that somehow along the lines, he came across a laced Percocet and decided to take it that night. And that pill was laced with fentanyl. The one thing I hope that comes across is that it can happen to you. That we cannot be so naive to think that just because we wouldn't do it, that our kids wouldn't do it. We can talk to our kids and say, hey, don't do this, but one time isn't enough. We need to keep instilling in them the values that, hey, it can be in anything now. It can be in a can of pop, it can be in anything. So you have to be mindful and educate not only yourself, but your children of the dangers of fentanyl. So I just hope that me sharing my story of a kid that no one would expect would take a pill did it. So don't think that for one second that your kid, he's a good kid, he's a star player, he's this and that, and that one instance that it could have been peer pressure. It could have been he just wanted to fit in. I don't know the exact circumstances, but I just hope that parents don't be naive in thinking that it won't happen to them.
on our website are the other 4 parent videos that we did for that 2022 Red Ribbon campaign. They're free to use by anyone who wants to utilize them. We have school districts, we have mental health service providers who use them on a regular basis to help educate parents about the need to be aware of fentanyl, the need to have those ongoing conversations with your youth. And with those videos is a parent's guide on how to communicate to your youth, to your young adults, about the impact of these drugs. So often, as parents, we have that one conversation, that one long lecture about don't use drugs, don't do things that are going to put you in harm's way, where we should be having 61-minute conversations with our youth and our young adults, really emphasizing the impact of real life situations, using those real life situations to help draw that connection to our youth and our young adults, because that is what is shown in the literature to be most effective in educating that age range. So I want to talk a little bit about naloxone. Naloxone is an amazing substance. It's a drug that was first developed back in the 60s. It is used to reverse opioid overdoses. And there are a couple of things that I want to draw your attention to. What naloxone does, and I'll show you some slides of this in a second, is it goes into the brain and it knocks those opioids off the receptor site and replaces them, which they can then arrest an overdose and help people start breathing again, which is a major, major issue when you're in a overdose situation. It's available in a spray, a nasal spray, as well as kind of an EpiPen auto-injectable. Works within 2 to 4 minutes of administration. But, and as we go to this next slide here, I'm going to highlight these 3 points. It only reverses the effects of opioids, or opiates, and it wears off in about 30 to 90 minutes. So it's not an alternative for emergency medical care. If you are responding to an overdose situation, which we'll talk about in a minute as well, know that the half-life of naloxone is not the same as the half-life of the opioid that somebody may have taken. So you can reverse an overdose only to have that person enter that overdose again about 90 minutes later. So always when using naloxone, make sure that you've contacted emergency medical services so that they can come out and fully treat and monitor the individual. Because we have seen that happen. A bystander was able to administer naloxone, but no medical staff were called. And then the person ended up dying later because those opioids reasserted themselves on those receptor sites. So naloxone works by binding to the mu receptor sites in the brain where most opioids tend to go. It strips those opioids off, causing the person to go into a precipitated severe withdrawal. Oftentimes, when using naloxone, you'll find when the person comes to and regains consciousness again, they tend to be confused and even at times a little combative, not knowing what's happening, and can start experiencing severe withdrawal symptoms, especially if they've been using a lot of opioids. Know that 30 to 90 minutes is that half-life for naloxone, and that you need to call emergency medical services anytime you're administering it. Now, naloxone is available over the counter now, which is great. It's still at a pretty hefty price point. In the state of Texas, it averages about $55 for a 2 spray pack that you can pick up at any local pharmacy or Walmart, CVS, wherever you happen to shop. Our Cook Children's Medical Hospital, which does amazing opioid stewardship work, now automatically gives a prescription for naloxone to any parent who gets a prescription for an opioid for a child. Because so often we have seen that those opioid prescriptions can result in becoming addicted. It does not take a great deal of time to become addicted to an opioid. In fact, if you look at the CDC and the Surgeon General, they recommend opioids only really be utilized 3 to 5 days after an injury. After that, the impact of that opioid on relieving pain diminishes greatly, and that addictive potential for that opioid increases dramatically. So it's always a good idea if you have a loved one who is using an opioid for prescription purposes or for recreational purposes that you have naloxone available. Having that naloxone available, I carry it in my laptop bag. I carry it in my car when it's not in the middle of Texas summer because unfortunately anything over 104 degrees and the naloxone starts to evaporate from the canister. But having that naloxone available saves lives. We have installed naloxone vending machines on our universities and college campuses. We've worked with all of our local school districts to have naloxone available within the AED defibrillators that are there at every first aid station. And we work a lot with the athletic trainers, with football, basketball, baseball, and the band, believe it or not, to ensure that everybody has access to naloxone so that they can step in and reverse an overdose. Because we see, unfortunately, a lot of them, especially in that young adult population. So how should you respond if you come across somebody who is in an overdose? Signs of an overdose: head can be tilted back with mouth open, eyes rolled back where you're only seeing the whites of the eyes. The person is unresponsive and cannot be woken up. The body is limp. The face is grayish in color or clammy to the touch. There's a bluish tint around the mouth or the nail bed. Breathing is less than 6 breaths per minute or has stopped. Or there's a deep, slow, snoring, gurgling sound that oftentimes you'll hear that are indicative of an overdose. To respond, first thing you do, of course, is call 911. Most of us have our cell phones on us, thankfully, and call 911, put it on speaker so you can immediately start providing aid to the person. But do call 911 first because those few minutes can be crucial, especially with anoxia and that lack of oxygen to the brain. So call 911, tell them someone is overdosing or that you're suspecting an overdose or that they're not breathing or is unresponsive, and try and give them a clear address and location. Roll the person onto their back as gently as possible to avoid injury. Start rescue breathing. Give naloxone. Most of the time, the naloxone that we have available is the nasal spray. So you do have to be mindful that if the person has vomited, you may need to check the nasal passage to see if it's obstructed, because oftentimes that can happen when a person has aspirated on their vomit. If that nasal pathway is clear, use the naloxone. And that naloxone can be given every 2 to 3 minutes until help arrives, until an ambulance arrives. So the thing you can also remember about naloxone is that you can't hurt anyone with naloxone. It does one thing and one thing only in the body, and that's knocking those opioid receptors off those receptor sites. So you're not going to hurt anyone by giving them naloxone. Most states, in fact, the vast majority of the states, have good Samaritan laws that protect you for administering naloxone because we want bystanders to be able to intervene and save lives. So that tends to be our focus. Even if your naloxone is expired, believe it or not, expired naloxone is still effective. So if you have an expired naloxone and that's the only thing you have access to, go ahead and give it. There's no danger in providing that naloxone. It may not be as effective as a fresh naloxone, but it can still save lives and has. All right, we're going to switch gears now, and we're going to talk a little bit about another huge issue we're having within the young adult and adolescent population, and that's vaping. So vaping, of course, has been the next step with cigarette use. For many, many years, we did a decent job in trying to educate people about the impact of smoking on your lungs, on your body, on the development of cancer. And over 20 years, we got the message out, and more people were aware. There were laws and policies passed to protect workplaces and airplane rides and eating out where smoking was not permitted. So then, what started off as a company who was looking at doing tobacco cessation, they created a device that allowed for electronic or atomization of nicotine. And then vaping became a huge issue for everyone. So let's talk a little bit about the effects of nicotine on the brain, because that's truly the drug that is involved when you're dealing with cigarettes or with vaping. Nicotine is that drug. And whereas a lot of people talk about gateway drugs, I don't really subscribe to the notion of a gateway drug. But if there was a drug out there that is going to give people enough positive pleasure and response that they're going to be prone to use it again and again, nicotine would be that drug. Nicotine is unique in that it impacts several different neurotransmitters in our brain. So it impacts dopamine, which increases your pleasure and suppresses your appetite. It has norepinephrine, which is cognitive arousal and appetite suppression. Acetylcholine, which is cognitive enhancement and arousal. Vasopressin, which improves memory, but also plays a critical role in social connection, that feeling of being part of a group. Serotonin, which is about mood modulation and appetite suppression, and at times a feeling of accomplishment. And then beta endorphin, which reduce anxiety and tension. So with one drug, you're going to feel increased pleasure. You're going to lose weight because you're suppressing your appetite. You're going to feel more cognitively and physically aroused and aware. You're going to have improved memory and a sense of social connection. You're going to have improved mood stabilization, and you're going to reduce anxiety and tension. It's no wonder that tobacco or that nicotine became a drug of choice for many, many people. This is also the hardest drug to quit. We have people in our family recovery court who have been sober from meth, from cocaine, from marijuana for 10 plus years, but still tend to relapse on nicotine because nicotine is highly, highly addictive. Fortunately, while we were using cigarettes, you weren't actualizing a great deal of nicotine per cigarette. So much depended upon the rate of intake, your drag, whether there's wind blowing outside, whether you were drinking coffee and talking while you were smoking. Lots of people only actualize about 1 milligram of nicotine per cigarette. Well, with the vaping devices, that amount of nicotine being absorbed has gone up exponentially. So, side effects of nicotine. There are lots of negative side effects of nicotine: increased heart rate and blood pressure, increased risk of heart disease, nausea and vomiting, especially when you start getting to the lethality dose of nicotine. And yes, believe it or not, nicotine can actually kill you, like many other drugs. There's a lethality dose involved. For adolescents, it's about 45 milligrams of nicotine. For adults, it's about 60 milligrams. And we've heard those old apocryphal stories about, oh, my dad caught me smoking cigarettes, so he made me smoke the whole pack. About halfway through, I turned green and I threw up. And yeah, that would be that nausea and vomiting side effect of nicotine. Dizziness, headaches, insomnia, that reduction of appetite, depression, difficulty concentrating after prolonged use, and then, of course, lung cancer. So all of these issues come into play with nicotine, regardless of your age, regardless of how you're using the nicotine. These side effects all occur. A lot of people quit to vape in order, or electronic nicotine delivery devices, as we call them, switched to vapes in order to quit smoking, thinking that, well, if I can just hit it when I need it, then I can reduce the amount that I'm smoking. Unfortunately, from a research perspective, that hasn't been effective. In fact, if anything, when people switch to vape to start atomizing nicotine, they are at higher risk of increasing their frequency and intensity of vaping and of subsequent cigarette smoking, even like among the newer generation, if they've never smoked a cigarette in their life. They're at a higher risk of starting to smoke because of that nicotine addiction. We also know that secondhand vape smoke actually does impair air quality. For a long time, people were vaping in movie theaters and on planes and in workplaces because, oh, there's no smell to it, right? Or if there is a smell to it, it's not pronounced as it would be with cigarettes. But what the research has shown us is that those ultrafine particles do find their way from the vapor and into the lungs of the people who are cohabitating in that space. In addition to that vapor, we're also finding the nicotine, the heavy metals that are part and parcel of electronic nicotine delivery systems, aldehyde and glycerin, all being inhaled through the lungs simply by being in the presence of people who are vaping. So with electronic nicotine delivery systems, there are so many different variations. These are just a few photos of examples of some of the nicotine delivery devices that are out there. There are, last count, about 460 electronic nicotine delivery systems on the market. Some are tank systems, some are pens, some actually resemble cigarettes, some are disposable, where you use it and then after 200 puffs, you throw it away. Unfortunately, they all have some pretty pronounced side effects because this was not a product that was regulated in the early days, especially. So there were lots of things that were added to these delivery devices that we have no research on what that's actually going to do to our health and our well-being. So some of the different items that are in these e-cig devices, there are humectants, which are the ability to mimic cigarette smoke. It creates that aerosol when heated, so that behavior mechanism that you see. Smokers still like to have something in their hand, and they like to see that vapor coming out. Well, that vapor contains propylene glycol and glycerol, which are the more popular e-liquid humectants that we see. And while they may be safe to ingest as a food item or as a pharmaceutical additive, it's also what's used to create artificial fog in theatrical productions. And believe it or not, AGMA and all the other theater organizations, they have limits to the amount of artificial fog that can be created in any show because it causes people issues with breathing. Long-term exposure to these substances, along with dozens of other chemicals that are often not even on the label because they're not being regulated, can be toxic in those higher levels. So we're playing a game of unknown here. We don't know what the long-term consequences are going to be of inhaling through your lungs these humectants. The other thing that we see in these devices are flavoring. The reason we flavor vape devices is because it makes them more palatable to younger consumers. That is the reality. We're seeing over 7,000 different flavors that make vaping a more pleasurable experience for younger adolescents and young adults. Remember, the younger you are, the more taste buds you still have active. We're born with all the taste buds we're ever going to have. And through living, we tend to kill taste buds. And when you're younger, your taste buds are far more sensitive, which is why our children have such strong reactions to certain foods like feta cheese. Give a 5-year-old a piece of feta and they will respond to it because it is a very strong, potent taste in their taste buds. While flavorings make that more palatable to that younger user. And while many of them are safe to ingest when added to food products, there's no research about what happens when you inhale that through your lungs. And I'm afraid we're beginning to see some of those issues. We saw it just a few years ago with the whole EVALE syndrome. When e-cigs first hit the market, they were being vitamin E solution was being added to them to help the burn through that atomizer happen more smoothly and to create that vapor. And that vitamin E oil was actually causing pronounced damage to people's lungs to the point where people were having to go on a lung transplant list because of their vaping. We also know that frequent vaping can increase the person's risk of developing high blood sugar. The link to diabetes and vaping, there are several well-researched studies that show that. They're also associated with about 200 other health issues, including brittle bones, erectile dysfunction, and even eating disorders. We also have a 2020 study that looked at the literature on the effects of vaping on your back, disc health, bone health, spinal fusion. All of it created oxidative stress and inflammation in the body, which made those back issues worse. But of course, our producers of nicotine and nicotine products continue to try out new devices. This, the Camel Variety Pack dissolvable tobacco, has been put on the market and pulled off the market several times in different test cities because the outcry from those communities is so pronounced when it happens. Camel decided to create dissolvable tobacco, which contained larger amounts of nicotine, and they did it through what they called strips, orbs, and sticks. So you had tobacco sticks, which looked very much like toothpicks that you would put in your mouth, and they would dissolve over a period of 5 to 7 minutes. Then you had the orbs, which were small little Tic Tac type mints that you would put into your mouth that absorbed the nicotine in about 90 seconds to 2 minutes. And then you had the breath strip. So using the same company that makes the Listerment breath strip, they created a film strip that had the nicotine directly on it that you could then directly absorb sublingually, just like the other two. So these products, when they hit the test cities, immediately sold out. People were ordering them in every capacity possible. And some of the early research indicated that it was the cause for a lot of oral cancers that were being seen in those test cities. So currently these are off the market, but we're now seeing nicotine gummies hitting the market, which well-intentioned, once again, I thought, this could be a nicotine replacement therapy. What we're seeing is people are just using them in addition to vaping when they're in those areas where they cannot vape. And nicotine gummies are definitely on the radar for public health departments across the United States because there's a lot of concern about how they're going to be used and who's going to have access to them. All right, we're going to move into dextromethorphan now. Dextromethorphan is a cough suppressant. It is that ingredient you find in over-the-counter products like NyQuil and Robitussin that help prevent cough and work by actually activating different parts of the brain that suppress that cough reflex. Unfortunately, if you use dextromethorphan in higher doses than recommended, it can create intoxicating effects. It can cause feelings of dissociation and that floaty opioid high. It can create hallucinations, and those psychoactive ingredients can actually create some mental health issues among people who are using them. The ones that we see most commonly are, of course, Robitussin and NyQuil. Any over-the-counter product that has dextromethorphan in it can be mixed in with sodas or sports drinks to create a wide variety of concoctions, often known as purple drink or lean or syrup, Memphis mud, Texas tea, lots and lots of different names. Unfortunately, to get that high, you have to use far more than the recommended dose. So we'll have young adults and adolescents who are drinking half of a bottle of Robitussin or a full bottle of Robitussin, mixing it in with a soda. And while they're getting that intoxicating effect from the dextromethorphan, they're also getting far more than the recommended dosage of aspirin, which creates rapid breathing, difficulty swallowing, ringing in the ears or tinnitus, blood of urine, diarrhea, nausea, dizziness, swelling of the face, eyelids, or lips, convulsions, and of course, liver damage long term. Then the CPM, the antihistamine that's in a lot of those products, causes severe and life-threatening symptoms like seizures, trouble breathing, weakness, loss of consciousness, severe dryness of the mouth, nose, or throat, bleeding from the skin, mouth, eyes, rectum, vagina, and possibly death. You also have the glycosine, which is the expectorant product that makes that cough more productive, and it can create severe nausea and vomiting. And then if that product contains pseudoephedrine, which many of them do as a decongestant, it too causes tachycardia or that irregular heartbeat, can create headaches, difficult breathing, increased anxiety, and bring about seizures. So we try and do a lot of community education around just because it's on the shelf at Walmart doesn't mean that it's safe to take in those doses. And a lot of people have that misconception that, well, if it's being sold at your local store, it can't be bad for you. It's like, well, it's being sold as used as intended. Supposed to use it in a very small controlled dosage. When you're using the entire bottle, you're getting so much more than you think you're getting with that. Kratom. Kratom is another issue that we're seeing. Kratom really became popular about the time that restrictions were being applied to prescription opioid pills. Kratom is from an evergreen tree in Asia. At low doses, kratom produces stimulant effects, with users reporting increased alertness, physical energy, and talkativeness. At high doses, it flips and actually becomes a sedative. So it provides that kind of opioid floaty high, which is why so many people switched to it when they were having a hard time getting a hold of an opioid. In fact, in Malaysia, they were using this with many of their military people to use that stimulant effect to keep people sharp and alert in different settings. Kratom consumption leads to addiction. The studies on that have been pretty clear. Lots of psychosis can result from the use of kratom. The DEA has been looking at scheduling this product, and there's no regulation on this product. So it's being sold in vape shops and head shops in a variety of different settings. You can purchase it on Amazon. You can purchase it on a variety of different websites. I've even seen it on eBay before. Unfortunately, there's no regulation on this product because it falls into that gray area. The Food and Drug Administration does no testing on it. So it's caveat emptor, or let the buyer beware. You can go into a shop and you can buy a particular kratom product, and it may not even contain any kratom, but it might. And neither one of those are good outcomes because we don't know what's actually in it. And people need to be aware that this product, while being sold as kind of a holistic, health alternative, is nothing of the kind. It's a product that can lead to pretty significant addiction, and we don't have a lot of treatment centered around kratom. In fact, it took us a couple of years to even get the Department of State Health Services to view kratom as an illicit substance that warranted moving into a residential treatment center for drug and alcohol treatment. All right, tianeptine. This is a newer product that we've been seeing over the last 3 years or so. What's scary about this product, it is a tricyclic antidepressant. So it is an established class of antidepressant that was used in Latin America, in Asia, and in European countries. It is not approved by the FDA and actually was denied FDA approval because of its addictive potential. So tyneptine, since it was never utilized in this country, has now been imported through a variety of sources and is being sold as what we call gas station heroin. So you see it as Neptune 6, Pegasus, Red Dawn, Zaza Red, Tiana. I mean, it goes by lots of different names. Sold usually as an elixir. You pick it up at the local, for us, our gas stations are QT or Racetrack. It is right there by the cash registers with no age restriction on that purchase. So we have young kids as well as adults and young adults using this product, thinking that it is a dietary supplement that they can use to increase their energy. It creates addiction in people very quickly. We've seen some cases where within a week, a person had started to increase their use of this product to the point where they were having heart issues, seizures, low blood pressure. We've seen some deaths occur because of this as well. Respiratory depression and severe sedation tends to be the primary things we're seeing. And it's also been found to include synthetic cannabinoids. So if you remember the old Spice or K2 epidemic back in 2006, 2007, where people were selling products as legal weed, many of those products have been repurposed and found their way into these proprietary mixes. You're not going to see it on the on the back of the bottle where it has what is supposed to be inside that product, but when you send it to the lab, you find a wide variety of other psychotropic drugs in there. This does create a significant withdrawal symptom and has now been one of those emerging drug threats that the Drug Enforcement Administration and the CDC have been sending out community warning announcements about, because it is so easily accessible. Like I said, sold in gas stations, on Amazon, vape shops, you name it, you can find it. Then we come to Delta 8. So Delta 8 came about through almost an accident. Back in 2018, when the Farm Bill was approved, it created the ability to cultivate hemp. And those hemp products have a small amount of THC because hemp and marijuana are the same plant. But usually with hemp, there's a THC level of less than 0.3 in any of those products. What has happened is it's opened a gray area market, and the manufacturers have taken Delta 8 and they have chemically inflated it where it is now as strong or stronger than actual marijuana, THC, the active ingredient in marijuana. And it's now being sold everywhere. I mean, gas stations, head shops, vape shops, you can purchase it online. It is amazing. Some states have begun a crackdown on this. In Texas, this has been an ongoing issue for us because so many of these vape shops that are selling Delta 8 are opening up literally blocks from each other and within our drug-free zones, such as our school zones or our churches. Delta 8 naturally occurs in hemp, but this is not a natural product. It has been artificially and chemically enhanced. In fact, we just recently had a raid of about 9 different vape shops in our area, and the products that they were pulling from that shelf and sending to the lab were coming back with 78% active cannabinoids in them. So that little 6% up in the right-hand corner, we know that when you send Delta 8 to a lab and test it, which is an expensive process, I'm telling you, 60% of the time, there's no Delta 8 in there. It's just THC. But when it is Delta 8, it is actually at times at a much stronger level than even what you would find on in marijuana. Many of these shops are calling themselves dispensaries now. In Texas, we do not have recreational or legalized marijuana use. There is some medical exemptions, but it is only in an tincture format and specifically related to seizure issues. So those states that still have not legalized recreational marijuana, Delta 8 has taken its place, and they're positioning themselves for that eventual legalization, I'm afraid. So the U.S. market for Delta 8 and THC, or hemp-derived cannabinoids, has increased 1,300% in the last 3 years. I've got a slide that I'll show you in a minute that shows you just how much sales are happening with this. The U.S. Cannabis Council did private lab testing on 16 different Delta 8 products purchased in these states. And in this test, all but one sample contained amounts of illicit Delta 9, which is the active ingredient in marijuana. We've also seen a staggering increase. 53% of cannabinoid-based poison control call centers in Texas involve patients 19 years and under. So kids are accessing this, young adults are accessing this, and they're using it not understanding that when you're using a product that you're having to actually digest through your stomach, that's a longer onset period for that high. So they'll take more than what's recommended, and it's impacting them in very significant ways. So here's that slide I was talking about. So in 2020 to 2023, billions and billions of dollars. We went from 200 million to over $2,774,000,000 in hemp-derived cannabinoid sales in the U.S. It is definitely a trend that we're seeing spreading across communities, and one that we're having to do a lot of education for not just youth, but for adults, because many adults hear that, well, this is a legal weed alternative. And you go into these vape shops and they'll tell you, oh yeah, there's no THC in this, so you won't test positive on a drug test, which in fact is not the case. Most of the time, you will test positive on both lab UAs, on a field UA, hair strand analysis, urine analysis. You're going to test positive. Some of our major employers have contacted us to come out and do training because they have pilots and people with security clearances who are making our F-16 who are failing drug screens after being employed there for 15 years because they thought they were using a product that was legal and therefore free for them to use. And that's not the case. Like I said, most of it does contain THC or is containing enough of that Delta 8 to warrant concern. Marijuana. Well, we're no stranger to marijuana, and the legalization has continued to across the United States. What I want you to make you aware of is that today's pot is about 275% more potent than it was 10 years ago. So that hydroponically grown weed that's now being sold at these dispensaries that are making their way to even those states that do not have legalized marijuana use, it is far stronger than the pot that people smoked back in the 60s and the 70s and the 80s. It has become, standard now is anywhere from 12 to 18 an active cannabinoid, whereas before it was about 4%. So that and the technology being used to vape these products or to ingest these products has changed dramatically as well, meaning that when you apply flame to a green grassy substance, you're going to be burning off the majority of those cannabinoids. In fact, you only actualize about 27% of the active cannabinoids when you're smoking, but when you're vaping, you are actualizing about 95% of those active cannabinoids. Far greater amounts than ever before. Now, we know there are 4 key uptake systems where the body can absorb cannabinoid. There's oral, there's ingestion through the gastric tract, there's inhalation through the lungs, and there's transdermal. All four of these methods will get you high, and all four of them are currently being used by the different products available for sale. Usually oral mucosal are the fastest ways to get into your system. Ingestion tends to be one of the slower ways, but we're seeing a variety of issues on all fronts. With our oral products, the things that are really marketable and profitable right now, lots of tinctures and drops that you put sublingually under the base of your tongue, awakening mints, which give you that wake and bake process. Take a little Tic Tac and it infuses your system with both caffeine and marijuana. We have THC infused toothpicks, which, if you're a child of the 80s like I was, people always used those cinnamon oil toothpicks everywhere they went. Now we have THC infused toothpicks that will bring THC into your system while you have that toothpick in your mouth. Then we, of course, have a wide series of edibles and tinctures and drinks. So you see a lot of soda companies and beer companies creating THC infused drinks that are available on the market, along with your candies. I think one of the more popular items are the Ripples, which are small flavor packets that you add to your bottle of water that infuse that water with a healthy amount of THC. Then, of course, you have inhalation through the vape, and you have transdermal patches, cream, and even personal lubricant products that are incredibly popular. We know some of the long-term outcomes with heavy cannabis use is a reduction of dopamine release in the brain. So if you're using cannabis heavily, you're actually reducing the amount of THC that is involved in that your body is naturally producing, which can create depression and anxiety and a sense of what we call anhedonia, or lack of pleasure in life. All right, now let's talk about alcohol. Kaylin?
Yes. Hey, John. Yeah, as we kind of head into these final couple of slides, just wanted to note we have about 5 minutes left for content here.
All right, perfect. Thank you so much, Kaylin. I'll move with all alacrity. So we know for a fact that alcohol still is a primary drug of choice for a lot of people. 1 in 8 American adults is an alcoholic. We know 1 out of 10 deaths in working age adults is the result of excessive alcohol use. We know that the body's ability to process alcohol declines with age, and that a smaller amount of alcohol can have a larger effect on older populations. What I want to really drive home for y'all today when we're talking about alcohol is that alcohol is actually a biphasic drug. It impacts brains differently depending on your age. The impact on the adolescent and young adult brain, so again, remember, up to 24 is that young adult brain, is different from the older adult brain. And we can liken this back to, if anyone, not that I'm going to ask for a show of hands, but if anyone used to go out clubbing, when you were in your early 20s, you could go out to the club and party till 2, drink some water, go home, get up at 6 a.m. and go to work the next day without a problem. Once you hit past that age of 25, alcohol no longer acts as an excitatory drug in the brain, but rather as a sedative drug, as it is a depressant. It is a central nervous system depressant, but for older adults, those over 25, alcohol tends to shut us down for the evening rather than exciting us for the evening. Young adults drink less often than older adults, but they drink more in any given setting, which of course brings us to binge drinking. And those who are engaging in heavy use drinking in short periods of time, it impacts that GABA in the brain, which turns down that chemistry of anxiety. There's a drop in IQ. It deregulates that L1 and diminishes cognitive functioning by about 25%. And it has some degradation effect on the hippocampus, which impacts memory, muscle memory, 3D spatial relationships, social behaviors, things like that. This is, on the far left, a healthy brain. And the 3 other slides are a 30-year-old 38-year-old male who has 17 years of heavy weekend-only alcohol drinking. So binge drinking has dramatic impacts on the physical functioning of that brain. We've seen a lot as of late, some public health concerns about alcohol energy drinks. These have been around for a while, but they're getting larger and the alcohol volume by content is increasing. The last thing you ever want to do for someone who is drinking heavily is to provide them caffeine because it just creates a wide awake drunk. It does not help a person sober up, despite all the myths about that. And it actually promotes risk taking because that caffeine as a stimulant is masking that impact of that alcohol. So young adults tend to take more risks when actually drinking alcohol and energy products together. In fact, there was a great study out of Wake Forest University that showed that college students who drank alcohol energy drinks drank more frequently, drank in higher concentration, and were far more likely, or twice as likely, to be hurt or injured, require medical attention to ride with an intoxicated driver because it impairs that ability to discern risk, to be taken advantage of sexually, or to take advantage of someone else sexually. So the combination of caffeine and other stimulants and alcohol is problematic. Of course, there are lots of new alcohol products hitting the market, being sold in far easier to conceal boxes or far easier to dispose of boxes. So the days of the big clunky glass bottle are behind us, and we're seeing wax like milk bottles almost, and just soda cans that are now infused with alcohol that are in a wide variety of different flavor combinations. We're also seeing things like powdered alcohol, which can actually be snorted. It is not recommended for that use, but we have seen it hit the market. We're also seeing things like alcohol-infused whipping cream. Should make family gatherings a lot more interesting around Thanksgiving if you're unaware. The thing about whipping cream is since there's alcohol contained in it, it does not require refrigeration. So we get a lot of calls from people concerned that somebody may be inhaling because of propellants in the whipped cream. Like, depending upon the brand, more than likely they're actually drinking rather than inhaling. We also see alcohol without liquid, which is an most of us have a device like this. If you have an asthmatic child, it's a nebulizer that actually distills that alcohol. You put the alcohol in the nebulizer, it shakes it into tiny little water droplets that people are then ingesting through their lungs. Incredibly popular in sororities around the state of Texas because you get all the bang of being drunk without any of the caloric intake, which has been a growing concern for universities. All right. And then, of course, we've also seen whiskey pods because, Tide Pod issue wasn't confusing enough. Now we have this is translucent seaweed that has been designed to hold the perfect shot of whiskey or scotch being sold. It's very popular in some of our upper echelon circles, but the technology continues to change and to develop.
Thank you,
And with
John.
that, I'm going to pass it
Yeah.
off to Kaylin and answer any questions.
Yes, unfortunately, we do not have any time for questions. We did have a few come through, so maybe I can convince John to circle back with us in a blog post or something to kind of circle
Absolutely.
back to dive a bit more into that for our service provider community. So if you do have any questions, we will capture that and I will circle back with John. Thank you so much for that really, really powerful and insightful presentation. It really is staggering to see all of that that is out and about in our world. And thank you all so much for all who have joined us today. For folks asking about CE credits, the link to this evaluation will be available on the event page. When you visit the event page, you will see the purple button, much like the one on the screen. We invite you to click that button, and then it will take you to first an evaluation. That is the first step in the process, and then a post test. If you do not see this button, especially if you have had the event page pulled up since the beginning of the webinar, please refresh the page or exit out and reload that page so that button will auto-populate. We will also put the link directly in the chat here in a moment. Your feedback is very important to us, so we ask our audience to take that short evaluation, letting us know your thoughts on today's webinar. And we will also circle back to your input there when we follow up with John on any questions that we may not have gotten to. A list of CE opportunities and accreditation agencies are available both on the slide right now, as well as the event page. So if you have any questions about what CE continuing education credit hours are available, please visit again that one-stop shop on the event page. Select certificates do require the completion of a post-test. Once you have completed that post-test with an 80% or higher, you should be emailed that certificate within 24 to 48 hours. Some email providers will kick that to your spam folder, so please be sure to check there first. And then if you have still not received your certificate in a timely manner, please reach out to us at ce@oneop.org. And that email, if you need to refer back to it, is available in the slide deck on slide 89, like you see on the screen. So if you need to email us, please feel free to do so. And we are happy to help you in getting your CE certificate. We invite you to join us for our next webinar. That will be on November 12th, and it will be on our Coping Compass series. We invite our participants to join that as we have a webinar on identifying and addressing problematic adolescent behavior. And of course, CE credits will be available for that session. We invite you to join us and subscribe to our newsletter and just make sure you're getting all updates on upcoming events, as well as blog posts and other materials that we share. So please, if you have not already, definitely be sure to visit our website and check out our other programming, as well as keep an eye out on our blog post, because hopefully we can have John contribute there and kind of dig a little deeper into some of the questions that we did have come through. Again, I did note those, so please be sure to visit our website and keep track on that as we hope to continue this conversation in that space. Thank you all again so much for joining us today. If you have any questions at all, please feel free to email us and we are happy to help. Thank you so much, John, for your time and really sharing your expertise in what is happening right now in these trends that we're seeing. So thank you all so much. We will keep the room open for maybe one more moment just so you can grab any last minute links. But again, I will plug, please visit the event page for today's webinar as your one-stop shop for anything you may need. Thank you all so much, and I hope you have a good rest of your week. And yes, just to note, the PowerPoint slides will also be available on the event page. So please check there under event materials. You should see not only the slides listed, but also a downloadable PDF of all of the links and resources that John also highlighted and shared, as well as the references and citations that he pulled from. So all of that is available on the event page. Thank you.